Morning, everyone, and welcome. I'm Lenny Bernstein, health and medicine reporter for the Washington Post. With me today is Ambassador Deborah Birx. She is the Global AIDS Coordinator and Special Representative for Global Health Diplomacy at the State Department. And Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases. Appreciate both of you joining us here today. To the audience and to folks who are watching online, you can tweet us your questions using the hashtag #PostLive. And if I can remember how this works, I will ask them. But let's get started. Dr. Fauci, I am old enough to remember some of the most dire predictions of the early and mid-1980s about what HIV was going to do to U.S. society and to our healthcare system. Right. Today, we are managing HIV like another chronic disease. Right. I thought it might be worth briefly just reviewing how we got here, and then perhaps what you think where we might be going in the next 5 or 10 years.
Well, Lenny, the best way to answer that question is just compare where we were back then to where we are right now, what the good news is, and then the sobering news, and then the challenges we have. Just a few days ago was World AIDS Day. That was the 30th World AIDS Day. And I can remember very clearly back in 1988, when we commemorated the first World AIDS Day, we had very few tools in the medical scientific sense to combat this in treatment or medically related treatments. And it was really a very, very dark time. What has happened over the years is that we've now developed therapeutic capabilities as well as prevention. And we've linked prevention and treatment in a way that if you fast forward 30 years from '88 to now, we can say without hyperbole that we have the tools, if implemented the way they could be implemented, to theoretically essentially end the epidemic as we know it now. That's the good news. That's the breathtaking scientific news. The problem is we have an implementation gap. We have not yet done that. And the implementation gap is huge. It's huge in this country and variably huge in other countries that you'll hear about from Ambassador Birx. So the challenge is in front of us. It's kind of, we celebrate what we've done, but we have to be actually sobered by what we can do and are not yet doing.
If we were here 10 years from now, and I was asking you the same question, where do you think we would be?
Well, where we would be or where I hope we would be. I mean, that's really important.
Tell us both.
Okay, where I hope we would be is that we would have such a successful implementation of identifying the people who are infected, getting them on therapy, getting their viral load to below detectable levels so that they cannot infect anyone else, getting the people at high risk on pre-exposure prophylaxis, and implementing in an aggressive way. Also, 10 years from now, I would hope that we would have at least a moderately effective vaccine. And that's something we're working very, very aggressively on right now. If we do that and combine even a 50 to 60% effective vaccine with the implementation of the scientific tools we have, that could be the nail in the coffin of HIV. It really could be. That's my hope. Whether it will happen, it depends on the political, economic, financial resources commitment of the entire world to get mobilized and do that. It's not going to happen spontaneously. That's the problem. Because people think we're doing so well, just stay on course. With an infectious disease, there's no such a thing as staying on course. You either suppress it or it comes back.
Dr. Birx, things are not as bright in the less developed world. Could you give us an overview of where things stand in Africa and Asia along these same lines?
Well, in some areas, it is very bright because we've been able to translate the incredible science and tools that you just heard about into effective implementation. But that requires political will from the governments of the countries who work and really engagement of communities. So it's not just resources, it's bringing together communities, governments, and resources and the correct policies to have a huge impact. And so we can see this spectacular progress in a series of countries because we put in absolutely accountability frameworks where we look at data every 3 months because we agree you have to move quicker and be aware to really stay ahead of the virus. And then we put surveys in the field to really look at yet whether we're having the progress and impact that we expect to have. And it's those surveys that have shown us in some countries like Swaziland and Lesotho, we have made spectacular progress. One country with less resources than the other country, but both countries with political will. And in other countries, we haven't made the same amount of progress. And then you have to really start to dissect, because you had the same tools. Why aren't you as effective? And I think that's what we ask ourselves every day.
Give us, what does spectacular progress look like?
Spectacular progress looks like where 85% of adults know their status. Because we're talking about a disease, HIV, with initial infection. It's silent in most people. So silently destroying the individual's immune system quietly, day after day after day, why they feel well. So when you try to figure out how do you get to a 25-year-old who feels well to interact with a healthcare delivery system that was never set up for them. It was set up for children under 5 and pregnant women. So a 25-year-old who feels healthy doesn't see themselves in need of healthcare. So we're having to really change how communities and individuals interact with the healthcare delivery system in order to be successful. And I think that's the real piece.
Knowing your status and being treated are two very different things. In a country like Lesotho, where you rightfully say there's been tremendous progress, what does treatment look like?
Well, it looks great because of the combination of PEPFAR, announced by President Bush in 2003, continued by President Obama, and endorsed by President Trump, to really continue that effort, mixed with the Global Fund resources and host country resources. So in Swaziland, the government of Swaziland buys a lot of the medication. In Lesotho, PEPFAR and Global Fund buys a lot of the medication, and about 60 to 70% of the individuals are on treatment. But the other side of it is what the 85% who know their status have to be on treatment immediately, even though they feel well, and the other 15% that don't know their status have to be found. And all of the seronegatives need to have effective prevention and effective prevention knowledge so they don't become positive. Because I really appreciated the opening where they talked about how sobering, yet it's fallen off the radar screen. We have millions of people infected every year and millions of people still dying, and it isn't in the press, and it isn't being discussed, and it isn't in the schools. And so 16-year-olds are becoming HIV positive who didn't even know they were at risk. And so we do have a communication gap and really creating a knowledge gap at the individuals that are most at risk. So we appreciate you doing this today because we think it's really going to raise awareness.
Same question I asked Dr. Fauci. If we were sitting in these chairs 5 or 10 years from now, what would you expect and or hope to see?
I think two things. We would love to see, and we think we can get there, a roadmap for success in this series of countries, because remember, it's political will with communities. And so countries that have that combination, we can make great progress and really show the world what controlling a pandemic looks like so that we're ready for the vaccine and the cure. We should know that historically this has never been done before. We've never controlled a pandemic without a vaccine or a cure unless it decimated the human population like the Black Plague, and then went away because everybody who was at risk was already infected. So this is really an ongoing and constant threat to us that we take very seriously every day to really figure out how we can do better, because when Dr. Fauci says we have the tools, we feel that gives us really the moral obligation to translate that generosity of the American taxpayer dollars that Congress has entrusted us with into programs that are going to have the impact that we know they can from the scientific evidence, and then we're responsible for making it happen with the countries and communities.
Okay, so it was about 8 minutes before I heard the word vaccine, and I was worried that I was going to have to raise it. So, Dr. Fauci, please tell us where we stand on a vaccine for HIV.
Well, where we stand is that we have a very compelling and difficult scientific challenge for the following reason. If you look at all the successful vaccines that we have made against the big killers and maimers, smallpox, measles, polio, even though there's a lot of morbidity and mortality, at the end of the day, the body has the capability of removing the virus in question, eradicating it from the body, and leaving you with the immunity to protect you against infection from the same virus. Unfortunately for HIV, that's not the case. The body does not know how to easily make an immune response because no one spontaneously recovers from HIV. So when we do the vaccine work, we have to do better than natural infection. When I was in medical school, we were told by our mentors, the best way to make a vaccine is to mimic natural infection without hurting the individual. Having said that, years of scientific work has now come in that we've made some significant progress. Several years ago in Thailand, when we were doing things together back then, we did a trial in collaboration with the Department of Defense when Debbie was in the Department of Defense with the Thailand government, and we showed that you can get a modestly effective vaccine, 31%. We were able to show what the correlates of immunity were. So now ongoing in Southern Africa are 2 vaccine trials, one that started in March 2017, which is a version of what we did in Thailand, only with some extra added boost and some adjuvants. Just literally a couple of days ago, an Imbokodo trial, which is also in Southern Africa, of another vaccine. So we're really, compare where we were years ago, we have 2 vaccine trials that are large trials that are going on in a high-risk population. Now, the thing we have to learn and appreciate about vaccines, Lenny, is that when you think about a vaccine, you say, well, you want a 98% effective vaccine. Measles is 98% effective. Yellow fever is 99% effective. I don't think we're going to get there with HIV because of the nature of the virus. But if we could get those vaccines that we're testing in Africa now to 55%, hopefully 60%, if you take that together with Debbie and I have been talking about the implementation, that's where I think we can end the epidemic. So vaccine will always be an important part of a durable end. I say durable because we've had situations with infectious diseases, for example, with certain countries in malaria, where you suppress it down to practically nothing and then you put resources someplace else and it comes right back. The only way you put the nail in the coffin of a viral infection is with a vaccine.
Are we trying to cure HIV?
Dr. Fauci's trying to cure HIV, but I think that's really important, and I'm glad you brought that up because really the people have been working very hard on that. And I think when you're talking about putting a new 15-year-old on treatment for life, to be able to say to them, there are people working on a cure, so that you need to stay on your drugs to keep your immune system healthy, so that when a cure comes, you can be cured, or when your functional cure comes, you can be vibrant and living without your treatment, but still being suppressed with your virus. And so, but it really requires you staying on your medication so you have integrity of your immune system when the cure comes. Right. So he's going to have a cure for us.
Well,
a functional cure.
But that regimen that you are currently trying to put 15-year-olds on, that's extremely difficult to maintain. Do people maintain that?
Well, that's why we are so excited about what the innovators are doing in the pharmaceutical industry, because they continue to work on more effective, less toxic regimens that are available in the United States, and then they immediately license them to generic companies so that we can immediately have access in the developing world. That is extraordinary. So when you think about what HIV/AIDS has done, it's brought communities and governments together in a unique partnership. It's brought programs and science together in unique partnerships. And it's brought companies together with the generics and the pharmaceutical innovators together to ensure that everyone has access quickly. So in January, we're going to be able to put a much more effective and much less toxic regimen in the field. And we're so excited about that because that's really what our 18 and 19 and 20-year-olds need to see.
So Lenny, when all of us were treating HIV-infected individuals back when we had first the finally combination of drugs, an average number of pills that my patients were on were like 20. They had to take it with meals, before meals, after meals, in the middle of the night. Now, you can have a single pill that contains 3 of the drugs and take it once a day. So when you say cure, you got to divide it into 2 buckets. If cure means eradication of the virus so that you never have to be on drug, that's going to be extremely difficult to do. Maybe impossible. But if you look at the other thing, can we get people off daily medications That's what we're trying to do. We're trying to get better drugs, some that you can give intermittently with an injection once every several months, or passive transfer of antibody, or boost the immune system so that it regains strength to suppress the virus so you could stop taking antiretrovirals. So people get confused.
You don't have to worry about missing your
Exactly.
your
We
pills
have a
1 or
study
2
that
days.
just started now in women in Africa where you give a single injection of a very long-acting antiretroviral that goes for months so that you maybe need to give it only every several months. That takes away from the stress and the stigma of having to take medicines every day.
Okay, we have a question on Twitter from Peter, who asks, President Trump has proposed to cut PEPFAR's budget by 17%. How would such a reduction affect the program's ability to provide much-needed ART, antiretroviral therapy, in developing countries?
Well, I think you could see connected with the president's budget was a very clear evidence base that said we will maintain everybody on treatment because the United States has that commitment to individuals we have started on treatment. And at the same time, the Secretary of State, Secretary Tillerson, launched a new, very aggressive strategy that really talked about what Tony just talked about, is how do we more aggressively do with the resources we have to get to the end of this pandemic as far as controlling it in a series of countries, and has really challenged us with a new strategy to get to control in 13 countries over the next 3 years. So I think that's why I made the point very early on about it's not just resources, it's political will and communities being able to support and the policies that are needed. If countries don't go to the ability for immediately testing and starting someone on treatment, it costs us twice as much to find them again later when their CD4 are lower. So every country today has to have that policy that every single person who's positive has access to treatment immediately. These are the things that make our dollars work more effectively and more efficiently. So our job is to take our resources that the American people give to us, and when you even say it, $5 billion a year, that is a lot of commitment of the American people and the American Congress to really trust us to use those kind of resources to really have the impact that we believe we can have. And that we get up every morning asking ourselves, are we delivering on those dollars that a family in Iowa entrusted with us? And do we track that dollar all the way down to the site of the client that we're serving? And are we serving them with quality and integrity and results? And that's our mandate. And we take that very seriously. And that's why if you go to pepfar.gov, we have all of our data up on our website down to the district level. So you can see the translation of those fundings into a site and the reach that they're having and the impact that they're having.
Dr. Fauci, I wanted to get back to something you mentioned at the beginning about the implementation gap. Right. So there are hard to reach populations for HIV. Right. Men who have sex with men, particularly African American men who have sex with men. They are becoming a much larger share of the people who have HIV infections. What are we doing and what are we not doing to reach that population and close the implementation gap?
Well, what we are doing, we'd have to show what the model would be in a different population. So just take the city of San Francisco. They have something that's called the RAPID program. And they essentially go out into the community and people at high risk, the homeless, gay bars, people who likely will get infected. They test them on the spot. They get the results before they leave the spot. If it's positive, they take a bag and give them a month's worth of antiretroviral. And then they say, we're going to ask you to call us at the end, and here's a prescription to fill it. If, in fact, they don't call and say, I don't have a cell phone, they give them a cell phone. That's a full court press, and they have done this with their infection rate. Okay, that's what they've done there. New York is trying to do the same thing with Governor Cuomo. But what you're talking about is a situation in the southern part of the country where exactly what you say, African-American group, mostly men who have sex with men, and the stigma and the culture associated with how you react to someone who's infected is a very difficult problem to solve. You're going to hear a little bit more about it when Mike Sack comes on another panel, because he lives in Alabama and can tell you about that. But we know, because we always talk to each other, it's almost like having a culture change. And Lenny, one of the things that's so difficult to change is a deep-seated culture that leads to stigma. And that's going to be a real problem in accessing those people. And that's the reason why they're kind of like the forgotten group on the bottom that you can't access, because they don't want to come out and say, what do I need to know about my risk? Should I be on pre-exposure prophylaxis? Because then you're essentially saying you're in a risk group, which immediately triggers stigma against you. That's a big problem.
Nor can you find people and give them a bag full of medications and a cell phone right there. It's a much more rural population.
Right.
So what do we do?
Yeah, we have to keep trying to get the people at the community to go out. You have to get community leaders to do that. I mean, a white guy in a suit like me going down there and doing that is not going to work. You've got to get the local community people to go in, educate them, and I don't want to say educate in the demeaning sense, but show them what they can do to help themselves. But they're always going to be left with that wall of stigma that is very tough to bring down.
How about abroad? Is the stigma problem the same, worse?
In some places it's worse, but what is so exciting is the domestic to global connection and the fact that we have communication now so much between the programs. So we learned from San Francisco and New York. So when we launched the DREAMS program, Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women, that we announced results of at this World AIDS Day, in just 2 years, we decreased incidence in young women, the largest growing group of new infections in sub-Saharan Africa, by 25 to 40%. That was only possible because we understood what San Francisco and New York was doing and where the South was, and that you needed to engage communities in the planning, in the implementation, and in ensuring the follow-up and results. And because the community of young women are leading the program, it's young women talking about HIV/AIDS to other young women. That decreases the stigma. And other groups like Johnson & Johnson and Gilead and ViiV really helped us do market segmentation, because like Tony said, this is not going to get me credibility with young women in sub-Saharan Africa. But Johnson & Johnson and others really taught us how to really develop that kind of community awareness. That's going to be important not only for preventing HIV/AIDS, but also preventing all the non-communicable diseases. So these platforms are going to be utilizable by governments to ensure a healthy society in the future.
We have a little more than 2 minutes. Dr. Fauci, Stacy on Twitter asks, how are issues like the opioid epidemic, religious freedom laws in Indiana, and opposition to needle exchange contributing to HIV right now?
A lot, shortly. So obviously, when you have an opioid epidemic, which is such a serious problem right now in the United States, that would then, as we know from experience, leads to injection drug use with heroin or whatever it is that's being injected. Once you get into that, we already have the example in a community in Indiana where they had the biggest explosion of a localized outbreak of HIV than we've seen in decades, but going back to the 1980s. That's really a critical issue. Needle exchange and not allowing needle exchange is a problem. We know that needle exchange works. During the Clinton administration, I was asked by Secretary Shalala, together with David Satcher, who was at the CDC and others at the time, to look at the data and ask a simple question. If you give needle exchange, A, does it promote drug use? And B, does it decrease HIV infection? And we found incontrovertibly that it does not promote drug use, and it definitely decreases HIV infection. And so if you don't allow the use of needle exchange, that contributes to the spread in certain populations. So those are the kind of things that we've got to implement.
And what about laws like religious freedom laws? Are those affecting this?
When you say religious freedom, what do you mean?
I'm
we have religious
Twitter
freedom.
here.
I think we have religious freedom in this country.
Yeah. Okay. We learned very recently, we're very low on time, that if you're the virus is undetectable in your bloodstream. You cannot transmit it sexually to others. We've known that for a little while. Now there's a big campaign to let folks know that. Is that message getting out? Does the average person know that?
I think that's our job, to make sure that the average person does know that, because that decreases stigma and discrimination. And it also makes it clear to that person that if they stay on their medication, and they're what we call virally suppressed, the non-detectable is untransmittable, if they're in that place, they can live not only a healthy lifestyle themselves, but not ever transmit the virus to others if they stay on their medications and they're virally suppressed. So you will see in those surveys that we talked about, we're measuring viral suppression in the community. And we're finding unbelievable clients who have 80–90% of clients have stayed on their medication, despite the fact that they've had to sometimes go weekly to pick up their pills. So this is how motivated our clients are. That's what motivates us to do a better job, because we are already working with people who have been extraordinarily adherent to their medications, and it's our job to make sure that everybody has access.
Gotcha, thank you. That's all the time we have for today. I want to thank Dr. Birx, Dr. Fauci for spending time with us, and I'm going to turn this over to my colleague, Eugene Scott. Thank you.